Well, hey there, everybody. Welcome to another Panopto recording here in Pharmacology. All right, so autonomic pharmacology. What does that mean to you? Autonomic, autonomic. Sounds a lot like automatic to me. And that's exactly what autonomic nervous system is. It is an automatic modulating system. So the things that are there in front of you on the screen all happen basically in the background. No conscious thought required, right? Blood pressure, heart rate, GI motility, generation of saliva, breathing, all things that you do on your own, whether you're awake or asleep. However, you know that conscious thought can influence all of these systems. So, getting stressed out, blood pressure goes up, heart rate goes up. GI motility, well, depending on if it's whether you're scared or angry, it could go one or both ways. Saliva generation. Well, if you're really stressed, for example, dry mouth, right? Bronchial smooth muscle. You're really stressed. Your respiration goes up. Your breathing gets more intense. So, yeah, these things happen in the background. But conscious thought can influence the systems and make them work in greater capacity or lesser capacity depending on the situation. So, to make it more clear to you, the autonomic nervous system is really divided into two systems or two divisions that work in opposite directions or essentially against each other. But what I mean by that is at any one time, one system is dominant over the other. So, let's say you're resting and digesting, right? Sunday afternoon, watching a little football, just sort of relaxing on the couch. Well, that's your parasympathetic autonomic nervous system, or the PANS, doing its job and sort of overriding the other system. Well, what if you're really stressed out right before an exam, or stressed out with somebody at work or at home, and you're really aggravated? Well, that's what we call the flight or fight syndrome, right? A lot of adrenaline flowing. Sympathetic autonomic nervous system, or the SANS. So at any one time, either one of the systems is dominant over the other. Well, one good way to understand the autonomic nervous system and its two divisions is to learn the two stories about me, your friend Tom Viola. So the first one is going to involve the PANS, okay, or what I call the bears on TV reaction. What does that mean? Well, if you're a Chicago Bears fan, or if you just know about the Chicago Bears, you know offense is not their forte. Great defense all these years, but throwing the ball and getting points on the scoreboard, not exactly their thing. So I would reckon that the Bears on TV is about as resting and digesting as somebody can get. You're sitting there sort of comatose. No real offense, so your pupils are relatively constricted as you watch the bright screen. Your respiration rate is normal to slightly decreased. And for that matter, your bronchioles are really not dilated. They're relatively speaking, based on whether or not you were really stressed and breathing heavily, they're relatively constricted in this situation. You're just kind of hanging out. Heartbeat is slow. Blood vessels in your muscles are, again, relatively constricted. You're not really using muscles other than to just sort of lay there. Blood vessels in your skin and mucosa are pretty normal. Clotting factors and endorphins, not released. They're not even necessary. You're not doing anything to injure yourself, to cause pain. Increased production of adipose and fat tissue. Well, if you sit there long enough, yeah. I know if you combine the pizza and beer into the equation, you're going to generate even more adipose and fat tissue. But that's okay. Think of it this way. You're generating energy for future use. And that's exactly what you are doing. While you're sitting there resting and digesting and snacking, you're really socking away glucose in the form of glycogen, and in some cases, when you've exceeded that quantity, fat tissue, for future energy needs, right? You need a constant source of energy going forward. And so now's a good time to stock up on energy. Decreased sweat production. Yeah, you're just sort of lying there. Hair is relaxed. Okay, well, if you saw my video and pictures of me, you realize by now no hair on my head is truly relaxed. The ones in the front are kind of scared for their lives. The ones in the back are singing Kumbaya. And the ones right above my temples are saying, "My, you look pale." But enough about my head of hair. Let's just say your hair is relaxed, not standing on end. How about increased GI motility and digestion? Yeah, you're resting and digestion, and yeah, the sphincters are relaxed to produce defecation and urination. So, yeah, you're using the facilities. So overall, increased GI secretions and increased saliva. Essentially, watching a football game like the Chicago Bears, bored out of your mind, you are just sort of resting and digesting, just sort of building up energy stores for the future. Not much going on there. Well, the other story of Tom Viola has to do with my one excursion into the woods on a hunting expedition. Now, to be fair, folks, I don't kill anything, not even stink bugs or crickets. And no matter how gross it is, I don't really kill anything except bees. Allergic to bees, so if I don't kill them, they're going to kill me. It's, it's a war. But anyway, so I go on this excursion into the woods, and let's face it, you know by now, I'm a city boy. I see something furry in the woods, and what do I think? Squirrel! Not necessarily. On this one occasion, it wasn't just a squirrel. It was a lot more than that. It was a bear. I wouldn't say that kind of bear. I'd say that kind of bear. Yeah. Complete with the teeth and all sorts of muscle ready to tackle me and turn me into chopped meat. Lucky for me, I escaped, but you could say that while a bear was in full pursuit, my pupils were definitely dilated. You think? Ever scare a cat? Yeah, you know exactly what I'm talking about. Respiration rate increased. Oh yeah. I was breathing pretty heavily. Relaxation of the bronchial smooth muscle. Yeah, I'd say my bronchioles were pretty dilated. I was doing some serious heavy breathing. Heart beat stronger and faster. I can't tell you how strong my heart was beating, but I thought it was going to blow up in my chest. Blood vessels in my skeletal muscles were dilated. Yeah, think about it, folks. This is fight or flight. So my lungs are dilated, bringing in all this oxygen. My heart is beating stronger and faster to get that oxygenated blood moving. Where? To my skeletal muscles, right? Fight or flight. But remember, at the same time, the blood vessels in my skin and mucosa are constricted. We're trying to minimize bleeding here and trying to conserve blood. So, you get really scared? What color is your skin? It's pretty pale, right? Clotting factors and endorphins released. Well, the bear did get me at some point. Just grazed me with a claw. But I had blood spurting out of my leg and had no idea. Again, clotting factors and endorphins to minimize the bleeding and the pain. Should have been bleeding a lot more based on the injury? Yeah, it was the clotting factors that saved me. Increased breakdown of adipose tissue. You could say that again. I lost about 5 pounds while running that bear. Increased glycogenolysis and gluconeogenesis. So in other words, folks, remember all that glycogen you stored up when you were having the pizza and beer? Now's a good time for that glucose to be released in your bloodstream. So glycogen is broken down into glucose, and you become a lean, mean, burning glucose machine. And all that burning means a lot of heat, and so you increase your sweat production to cool off, which again goes back to the caveman days. Those that are slippery live to tell another story and live to move on to another day. So the more slippery a sucker you are, the more likely your predator is going to lose its grip, and you are going to live to talk about it. So, my friends, what about my hair in this situation? Well, little I have was standing on end. That didn't really scare the bear. He was covered in it. How about relaxed GI motility? Yeah, nothing going on down there, okay? I wasn't regular, quote unquote, for weeks. And you might say, wait a minute, that goes against popular thought, doesn't it? I've heard of this expression, scared blankless. Yeah, but no. I mean, maybe some people, but in general, when you're scared to death, that's the last thing your body's devoting energy to. Sphincters are contracting. Oh, yeah, things were contracted, all right. Decreased GI secretions. Yeah, I had cotton mouth for a week, okay? I had nightmares about that thing, so I was pretty dry. So you get it, folks. The two different stories of me tell you a lot about the autonomic nervous system. And so let's talk a little bit about this, and you can kind of put this to use. So, in the PANS, what we're looking for is the neurotransmitter acetylcholine, and we're going to say that the receptors at the synapse near the organ that's affected, well, they'll be known as cholinergic receptors, from the word acetylcholine, but they'll have a special name. They're called muscarinic cholinergic receptors, to differentiate them from the majority of all of the other receptors, which are really lumped together as nicotinic receptors. So, in English, avoid using the word nicotinic in pharmacology. We don't use drugs at nicotinic receptors. We use drugs at muscarinic receptors. Why? They're located just where we want them, at the organ. And remember, from 2 classes ago, we use drugs because drugs act selectively. And you can see here, if you have the illustrations for this handout, that at the top right, the last junction, the last neuronal junction, right? The last neuron right at the organ. In this case, upper right of the screen, muscarinic receptors. Acetylcholine is your neurotransmitter. So in the PANS, we've got 2 different types of drugs. We've got cholinergic agonists and cholinergic antagonists. Now, the people who write the board exam like you to memorize long words. I don't know, I'm from Brooklyn, so this word is immediately outside my vocabulary because it's over 5 letters. Huh, just kidding. Parasympathomimetic, or mimics the PANS. Parasympatho. Cholinergic antagonists block, right? Anticholinergic. They block this cholinergic system. They block the PANS. So we're going to call these parasympatholytics. I don't know, I guess lytic from enzymes, right? Lyse. Let's just say it's an antagonist, but parasympatholytic versus a cholinergic agonist, parasympathomimetic, mimicking the PANS. Well, what about the SANS? Well, in the SANS, believe it or not, we still have those same nicotinic receptors, but again, we're focused really on the last neuronal junction with the effector organ. So we really want that last junction, and there the neurotransmitter is norepinephrine. And you'll see 2 different kinds of receptors, alpha and beta. But they're called alpha adrenergic and beta adrenergic. Where does the ADREN come from? It comes from the brand name of epinephrine, adrenaline. Did you know that? Adrenaline is a brand name. Go figure. And so we have norepinephrine, which is usually on duty at all times. And then you have epinephrine, which is really only released from the medulla part of the adrenal glands in that flight or fight syndrome. So now we're in the middle of the screen on the right, and you can see that the SANS is there. The receptor is labeled adrenergic, right, after adrenaline, and the neurotransmitter is norepinephrine. Okay. So again, the lovely people that write the board exam want you to memorize these words, but they're much like the words we learned before. If something is an adrenergic agonist, we call that sympathomimetic, as mimicking the SANS. And if we say something is an adrenergic antagonist or a blocker, we're going to call that sympatholytic. Well, the interesting thing is that adrenergic receptors are much more complicated, but don't worry, read that as easy, much more complicated than the muscarinic receptors you find in the pants. The adrenergic receptors are either alpha 1 or alpha 2, and the beta receptors are either beta 1 or beta 2. But let's go back. Okay, so we'll start back here at alpha 1. Where do you find alpha 1 receptors? In the skin and mucosa. And stimulating those alpha 1 receptors causes vasoconstriction. Now here's where you put the stories to use. You say, man, I'm lost. What did he just say? Well, here's the thing. If I say a Greek letter, like alpha, a Greek letter indicates SANS. Okay, SANS. Well, where is Tom Viola when he's the SANS man? He's in the woods. So what color was Viola's skin when he was in the woods? He was pale. So now you know. Alpha 1, alpha, SANS. Effect on the skin? Skin was pale. Vasoconstriction. What about the size of my pupils? I don't know, you say. What is it? Think. Okay, SANS. He's in the woods. He's terrified of the bear. His pupils are dilated. The word for dilated pupils, mydriasis. They're in the middle of your screen. So folks, if you don't remember a specific effect, just think of the story. Okay, hold on alpha 2. We'll come back to that. Let's talk about the beta receptors. Beta 1, beta 2. Okay, well, first thing is, where are they located? Beta 1 receptors on your heart. You have one heart, beta 1, right? All right. I don't know. What would the effect be on beta receptors? Well, he just said beta 1s are located on the heart. Well, what was his heart like when he was SANS man? Well, when he was SANS man, he was in the woods. His heart was beating forcefully. It was beating quickly. Yeah. Well, the words we use for that are inotropic and chronotropic. Inotropic for force, chronotropic for rate. So, yeah, increased force and rate of contraction. What about blood sugar? You say, I don't know, he never mentioned blood sugar. But I did. Remember, I said when I was in the woods, I burned up a lot of glucose. So yeah, that's when all that glycogen was converted to glucose. So you can say that the effect on the beta 1 receptors when it comes to blood glucose is hyperglycemia. Beta 2 receptors, where are they located? On your lungs. 2 lungs, beta 2. What's the effect of the SANS on beta 2 receptors? You say, I don't know. Think. Viola, woods. So beta, Greek letter, SANS. Viola, SANS man, woods. In the woods, what was Viola's lungs like? Dilated. Bronchodilation. What about beta 2 receptors in your blood vessels in your skeletal muscle? You panic. I don't know. Did we talk about blood vessels in the skeletal muscle? Yes, we did. Beta, Greek letter, SANS. SANS man, Viola's in the woods. What were the blood vessels in his skeletal muscles doing? They were dilating to let more of the blood into the skeletal muscles so he can fight or flight. And there you have it, my friends. You really can't get this wrong. Provided you remember the story, you almost certainly will get the answer correct just by thinking about where I was and what I was doing or what I look like. And again, the adrenal medulla is the central part of the adrenal gland from which the adrenaline itself, epinephrine, is formed. And when stimulated, when you're in that fight or flight situation, people say, my adrenaline was flowing. They're not kidding. The adrenaline, or epinephrine, is released from the adrenal gland and gets into the bloodstream and quickly starts the SANS reaction. Now, the interesting thing here is that many organs receive both the PANS and the SANS. And as I said, they work opposite each other. And at any one time, one system can dominate the other. So I know you have this slide, and this is a good slide to help you review the things we just talked about. On the left-hand side is the SANS in red, and on the right-hand side is the PANS in blue. And you can see that in almost every case, right? Every case, the two systems have the opposite effect on that organ. And so that's where we get the ability to use different medications. So for example, suppose I had someone who had xerostomia. Well, just using this slide, what kind of drug would I want to give that person? A parasympathetic drug or a sympathetic drug? Well, clearly on the right-hand side you can see parasympathetic helps you secrete saliva, so I want to give you a parasympathetic drug. At the same time, if you had asthma, well, what kind of drug would you want to take then? Well, let's see. Look down to the lungs. The PANS is constrict bronchioles. The SANS is dilate bronchioles. Heck, I'd want to use a SANS drug. Is there a SANS drug that's used to dilate your bronchioles to help treat you if you have asthma? Yeah. One of the most popular drugs we have. It's called albuterol. So we've got quite a few drugs that work in the SANS and or the PANS to get the job done. Because this system is so regular and so methodical and so behind the scenes that it makes a great place to use a drug to get predictable results. Now, the neuromuscular junction, which you saw in that slide, and I'll bring it up again, is not part of the autonomic nervous system. But because the same neurotransmitter and receptors are located there, it's often discussed with the autonomic nervous system. So at the bottom left, you will see the neuromuscular junction, what we call the somatic nervous system. And you can see there are those nicotinic receptors. So remember, Viola says avoid nicotinic. Now you know why. If you took a look at the left-hand side of this entire slide, you will see nicotinic receptors in the PANS, nicotinic receptors in the SANS, and even nicotinic receptors in your skeletal muscle. Not a really good idea to use a nicotinic drug, therefore, because it would have effects everywhere. And nicotinic sounds familiar, doesn't it? Nicotinic, nicotine. Yeah. Ask anybody who smokes tobacco cigarettes or vapes nicotine, and they will tell you they get this weird combination of PANS and SANS and skeletal muscle effects all going on at the same time. So they get this nicotinic effect where, you know, they're kind of relaxed, but at the same time they get a little jittery, and at the same time their muscles seem to twitch. Kind of weird, right? Because the drug is working on all these different receptors at once. And that's not really what we want as a drug, remember? As a drug, we want it to work selectively. So we really want this drug to work right there on the right-hand side. Muscarinic or adrenergic receptors right there at the effector organ. Well, my friends, it's Puss in Boots. Oh, there he is, the legendary Shrek character. And if that's not a good idea of offering up an example of dilated pupils, I don't know what is. So what about the PANS? Well, you can see that in this situation, the PANS is all about acetylcholine. Acetylcholine is released and interacts with muscarinic receptors on the other side, and we get our PANS effect. Now you'll also notice in this diagram that acetylcholinesterase is an enzyme that breaks down excess acetylcholine in the synapse and sends it back for reprocessing. But bottom line here, acetylcholine is our friend. It is our neurotransmitter to get our function. So let's talk about agonists to begin with. All right, I say cholinergic agonist. You say slud. Careful now, that's a D at the end, okay? Slud, 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 slud. Okay? Salivation, lacrimation, urination, defecation. Okay? So why do I say think slud? Well, I need you to remember them together because they all go together. What do I mean by that? I mean, if I gave you a drug to make you salivate, well, it'll make you salivate. It'll also make you lacrimate, urinate, and defecate. So you'll say, hey, thanks for the extra saliva. Where's the toilet? And you have a tissue because I'm crying like a little baby. So, yeah, you get the good with the not so good. We can treat using the autonomic nervous system, but lots of side effects. Some of them are tolerable, some of them aren't. So what do we get when we stimulate the hands? Well, we get things like me on the couch with my pizza and beer and overdrive, okay? Salivation, right? Increased movements in the GI leading up to diarrhea, okay? What else? Yeah, tear production, what a shock. Pupil constriction, the word for that is meiosis, and obviously increased urination, slud. So what do we use these drugs for? Well, as you might imagine, treatment of xerostomia, at least off-label, treatment of Sjogren's syndrome, so the drug pilocarpine, Saligen tablets, and the drug cevimeline, Evozac. And these two drugs are used to treat Sjogren's syndrome, and off-label to treat routine xerostomia. But again, we're talking about the PANS system and an agonist of the PANS. So that's it, pretty much. Sometimes used to treat glaucoma and sometimes Alzheimer's disease. But you'll find that there's less use for agonists than there are for antagonists. So, patient care considerations. Increased saliva, increased urine. Makes for a not so happy camper as a patient, getting rid of your dry mouth and getting rid of your dry undies. Well, that's a patient care consideration, an adverse reaction. And we'll talk a lot about those this semester. What's that word at the bottom? Contraindication? Oh yeah. So you'll see this word a lot. This is where when you have this condition, you would not necessarily want to use this drug. It's contraindicated. So, as you might imagine, you really would want to give someone a drug that increases stomach acid production if they have a peptic ulcer. Okay. But what about antagonists, cholinergic or PANS antagonists? Well, again, you've got this drying effect. Remember? Cholinergic agonist, slud. So, what about a cholinergic antagonist? Well, that would really be what? Anti-slud. Well, what about the brain? Some of these drugs do penetrate the brain, and some of them do cause more CNS side effects, drowsiness, things like that. But bottom line is, I want you to think anti-slud. So, cholinergic agonist, slud. Cholinergic antagonist, anti-slud. So, dry mouth, dry eyes, difficulty urinating, difficulty defecating. So what are the effects? Well, you'll see things like relaxed GI smooth muscle. Wait a minute, that sound, yeah, you got it, folks. So if you haven't picked up on this yet, antagonist of one system is just like the agonist of the other. So you could say that a PANS antagonist does the same thing as a SANS agonist. Right? Since they work opposite each other, the blocker of one is really like the stimulant of the other. So yeah, thinking about blocking the PANS. You're like, wait, I forgot. I'm so confused. No, you're not. Think of the story. When was I PANS man? I was watching football on the couch, pizza and beer. Okay, but this is anti-me on the couch. Or is it? I'm confused. Don't be. We're talking about PANS antagonists. Me on the couch, opposite. So, what can you expect? GI stasis. Things aren't really moving along. Bronchodilation, because when I was on the couch, I was relatively bronchoconstricted. Urinary stasis, because when I was on the couch, I always keep getting up to use the bathroom. So, I say PANS antagonist, you think of me on the couch as PANS man, and then everything opposite that. Okay, size of my pupils, let's see. Okay, I am on the couch in the living room. My pupils are relatively constricted because the room is dark and the screen is bright. That's me as PANS man, but this is anti-me as PANS man. It's an antagonist. So you can expect pupil dilation. So what do we use these drugs for? Well, if you've ever had surgery, you know that's exactly what they do. They give you a drug like this to dry you out, inhibit secretions from your nose and your mouth so that you won't aspirate them while you're under general anesthesia. How about you've got hypermotility of the colon, irritable bowel syndrome? Well, why don't we shut that down? Give you an anti-PANS drug for that. Same thing with incontinence, an overactive bladder. Give you a drug that stops the flow, like Detrol LA. And even if you get motion sickness, transderm scope, the patch of scopolamine, does a very good job in treating that part of the brain that causes motion sickness. And it does so because of its PANS activity and the fact that it can get into the brain. All right, what about visualizing your retina? Well, we said dilated pupils. What about uses in dentistry specifically? Well, using these drugs, again, they're anti-slud. So anti-salivation means dry mouth, which means, hey, a nice dry field to work in. And we'll talk a little bit about this at the end of the semester, the reduction of extrapyramidal side effects, EPS. But hold on to that thought. We'll talk about that much later in the semester. So adverse reactions. What can you expect from a PANS antagonist? We said dry mouth. We said blurred vision to some extent, right? Because the pupil is being dilated. Urinary and GI stasis. Nothing going on, right? It should be flowing, but it's not. And fever and sometimes hyperpyrexia because you don't sweat. So these are all adverse reactions of this anti-PANS drug. And a lot of drugs have these anti-PANS or anticholinergic effects. And you'll read that a lot when you're doing your homework. Anticholinergic this, anticholinergic that. So anticholinergic, meaning anti-PANS. And since one type of drug, let's say the psychotherapeutics drugs, they cause anticholinergic effects, and now you add on Benadryl or an antidepressant, and they cause anticholinergic effects. Now you've got that additive effect where each drug individually causes it, and now you're taking those drugs together, so they're adding up quickly. Okay, contraindications. Probably wouldn't want to give a gentleman who has an enlarged prostate and difficulty urinating a drug that makes it even more difficult for him to urinate. Anti-slud drug. So that would be considered a contraindication. All right, What about the autonomic signaling modifiers? We're talking about the drugs used to treat erectile dysfunction. Drugs like Viagra, Levitra, Cialis. Cialis, by the way, proof positive that someone in the government has a sense of humor. Why else would you name a drug for erectile dysfunction? Ta-da! Lafil. Somebody's getting a good laugh over that one somewhere. Oh, wait, did I have that? No, I didn't. Okay. How about adverse reactions? Well, ask any red-blooded American man if he cares if his erectile dysfunction drug gives him a headache. Whatever. Stuffy nose? Abnormal vision changes? That could help the situation. Excessive smiling. Well, yeah, I guess. No, I just threw that in there. That's not really a side effect. But why do we talk about these in a dental course? Pharmacology? What does this have to do with dentistry? Well, believe it or not, there are drugs that we use in dentistry that can affect these drugs. And probably the most common one we see is a drug called diflucan. And you'll see that drug when we talk about antifungals. Diflucan or fluconazole, useful for oral candidiasis, but because it's a liver enzyme inhibitor, it can inhibit the breakdown of these drugs like Viagra, Levitra, Cialis, and actually cause a situation or a condition.
Yeah, baby!
All right, cut that out. Can actually cause a situation like priapism, an erection that lasts longer than 4 hours, to which you now need to seek out medical attention. Don't ask me how you actually get there. I wouldn't recommend taking public transportation, but somehow you get there. Well, are there any situations where you wouldn't want to use these drugs? Or, where maybe you've got an issue completely with dentistry? And that would be, I think the only time would be when you're thinking about using nitrous oxide on a patient who's taking these medications on a regular basis. In theory anyway, because nitrous oxide is a vasodilator, much like a nitrate. And so you've heard the commercials by now, I'm sure, many times. Don't take this drug if you're taking nitrates. It causes a serious drop in blood pressure. Well, I guess that could be true of nitrous oxide too. So we tend to look at that as a contraindication, at least a relative contraindication. I say priapism. What do most men say?
We have a problem.
Yeah, you're not kidding. Okay. What about SANS agonists and antagonists? Well, let's finish this up, folks, okay? And now I give you the alpha-2 receptor. Can you see it on this slide? We didn't talk about alpha-2 before. I said hold that till later. Now, if you're really observant, you will see it where? Up there? Yeah, the alpha-2 receptor is located on the right-hand side presynaptically. Well, why would you want to have a receptor on the opposite side of the synapse? Well, think of it as an emergency shutoff valve. Okay, as the norepinephrine, or in this case epinephrine, are crossing the synapse, if the flow is so great because the stress is so great that it starts to overfill the synapse, well, it will reach up to the alpha-2 receptor, stimulate that, and the alpha-2 receptor will cause the flow to shut down. So think of it as an overflow valve protection system, okay? Protecting the overflow. So alpha-2 presynaptic. Stimulating the alpha-2 shuts off the flow of norepinephrine. We're going to see that used later by a drug. So a drug that will stimulate the alpha-2 and sort of shut off the flow of norepinephrine and sometimes epinephrine, allowing for less SANS reaction. Well, why would you want that? Well, how about if you have hypertension? That could be one reason why you may want to slow down the SANS, right? Okay, getting back to our normal receptors, alpha-1, beta-1, and beta-2, you can see they're all on the other side of the synapse, postsynaptic, right? Okay. So let's talk about some SANS agonists. All right, so what do they cause? Well, let's see. I don't know. SANS. Wait a minute. When was Viola Sandsman? In the woods. All right, so was he excited and alert? Yeah. Were his pupils dilated? Oh, yeah. Bronchioles dilated? Yeah, again. And did he have xerostomia? Yeah, cotton mouth for a week, okay? So the only one that was drooling in the woods that day was the bear. And yeah, you got it, folks. If you had to guess, right? If someone hit you with a question like, quick, what's the effect of the sands on blood sugar? I don't know. Sands, Viola, bear in the woods. Yeah, increased blood sugar, hyperglycemia. Just like that, folks. It'll get easier as you practice. So what do we use these drugs for? Well, lo and behold, since in the sands I had all that pale skin, yeah, we now know that using a sands agonist like epinephrine is quite common in dentistry combined with local anesthetics to cause vasoconstriction. While we're at it, same reason why we use Sudafed. Sudafed constricts the blood vessels in your nasal membranes, makes them shrink, and therefore opens up the airway so you can breathe. Okay. Treatment of asthma. Talk about breathing. Same thing, right? When was Viola Sandsman? He was in the woods. What were his bronchioles like? Dilated. Great treatment for asthma. Epinephrine for the treatment of anaphylaxis. Okay, epinephrine is used for anaphylaxis. Why? Well, in this case, think of maintaining a patent airway. Epinephrine causes relaxation of the bronchosmolar muscle, bronchodilation, and keeps the airway open. Treatment of shock. Dopamine is a very good way to get things moving again. If you've been involved in a case where you've experienced shock. Treatment of cardiac arrest, epinephrine. Yeah, think John Travolta, Pulp Fiction, intracardial injection of epinephrine. If you're too young to remember Pulp Fiction, just remember this. One good way to get your heart up and running again is a good dose of epinephrine. Ask any one of your patients who gets epinephrine in a local anesthetic injection. That's all about getting your heart up and going. Well, there's the drug we talked about before. Alpha-2 receptor agonist. Stimulating the alpha-2 causes a premature shutdown in the flow. And that is probably a good way to treat hypertension, right? Shut down on the heart beating faster, shut down on the force of the heart getting stronger. Yeah, good ways to cause hypertension to decrease. What else? Weight loss. Stimulate your sands enough and you will lose weight. Like phentermine, at one time part of the infamous duo Fen-Phen. Treatment of ADHD, like Ritalin. Now you might say, wait a minute, how does that work out? How does giving someone a stimulant make their ADHD better? Isn't their mind already racing away? Yeah, folks, that's the conundrum with ADHD medications. Think of it this way. When I was in the woods, I had a lot of thoughts racing through my head, but I was supremely focused on one thing, the bear. So when you overstimulate the brain, all of the distractions leave and you become hyper-focused on one thing. So that's the treatment for ADHD. Treatment of narcolepsy, when you fall asleep at very inopportune moments or at a moment's notice. That's like when you're watching a pharmacology video. And how about treatment of premature labor? Yeah, sands, woods, bear chasing me. Not a good time for someone to pop out the alien, okay? Keep the alien in. All right. So, patient care considerations. You got it. Adverse reactions from the SANS agonists, anxiety and tremors, palpitations. It's like causing a SANS reaction when there's no bear. And so patients get disturbed because their heart's racing away, and it's very uncanny for that to happen when there's nothing to cause it, at least in their mind. And you could even have additive central nervous system effects, like if, for example, You're already on a stimulant, and now someone gives you a dose of epinephrine. You decided the best way to spend 3 hours with a hygiene student is a massive dose of cocaine. Okay, well, now the hygiene student gives you epinephrine, and yeah, it's not a good idea. So when would I not use a SANS agonist like epinephrine? Well, the patient had uncontrolled angina, uncontrolled hypertension, or even something like hyperthyroidism. Let's talk about SANS antagonists, the SANS blockers. And what we'll see is we're going to talk about alpha blockers and beta blockers and all sorts of things that block the alpha and betas in the SANS. Now when you get to this slide, folks, the slide that talks about reserpine and guanethidine, the good news is you can pretty much ignore this slide because these two drugs are gone now, I believe, and so you don't see them very much at all anymore. So let's talk about alpha-1 blockers. Okay, now this is where the story will help you. All right, he said alpha-1. All right, he said the Greek letter alpha. That means SANS. That means he's in the woods. Alpha-1, skin and mucosa. So that means vasoconstriction, but this is an alpha-1 blocker. It's opposite him in the woods. So what do you get? Vasodilation, or a decrease in TPR, total peripheral resistance. What else? Well, let's see. I'm in the woods. My pupils are supposedly dilated, right? Checking out the bear. But this is a SANS antagonist, so I've got meiosis going on, or constricted pupils. So what are the uses for these drugs? Well, treatment of hypertension, right? Dilate those blood vessels. But you'll see the majority of these drugs are used to treat prostatic hypertrophy, to shrink to some extent or reduce the symptoms of in men an enlarged prostate that makes it difficult to urinate. Okay, so what do we get? What kind of side effects? Well, we're talking about vasodilation here. So we're talking about orthostatic hypotension, right? Move the chair too quickly, don't give them enough time to stand up and get their bearings, and down they go, right? Postural hypotension. And that can lead to drug interactions with, again, other drugs that cause that hypotensive effect, decrease in blood pressure. What about beta blockers? There's a word you've heard a couple times, I'm sure. Well, beta blockers work against the heart, right? So, beta, Greek letter, viola, woods, heart beating away. But this is a beta antagonist, so the heart's not beating so quickly, not beating so forcefully. Lowers blood pressure. And there are two kinds of beta blockers. There's the non-selective and the selective. Well, the non-selective, unfortunately, work on not only beta 1, but also beta 2. As it turns out, my friends, your body's beta receptors 1 and 2 look a lot alike. So unfortunately, that means some beta blockers like propranolol end up blocking both. Now wait a minute, Viola. Beta 2, lungs, stimulating, woods, bronchodilation. But this drug blocks that effect, so it's causing bronchoconstriction? Yes. One of the reasons why we really don't use propranolol in many people because it can cause difficulty breathing. However, patients with migraine headaches, patients with stage fright, anxiety, they will use propranolol because the benefit of using the drug and lowering their symptoms, getting rid of their symptoms, outweighs the risk of the potential difficulty breathing. So we like using selective beta blockers if possible because they work on the beta 1s more than the beta 2s and cause less difficulty breathing. Wow, look at the list of indications for these drugs. Arrhythmias and angina and hypertension. We're going to talk all about those in the next unit, cardiovascular drugs. But there you go, migraine headache prophylaxis, treatment of anxiety due to stage fright. So you're going to see a lot of these drugs being used outside, if you will, of what you might imagine. And that's due to the fact that there are alternate uses for these drugs. Okay, so type of side effects you might see from a beta blocker. Fatigue. Whereas the nice people that write the board questions say, you feel blue. Blue like a Smurf blue? No, just blue. Not blue, literally. You know, figuratively. You got the blues. You're kind of, kind of depressed. Fatigued, depressed. What about drug interactions? Well, think about it. Beta, viola, woods, elevated blood sugar. But this is a beta antagonist, so the blood sugar, instead of being high, will be low. So I've got low blood sugar, and now someone gives me medications to treat my diabetes, my blood sugar is going to go even lower. Plus, beta blockers can mask the signs and symptoms of low blood sugar. You know, the sweating and the palpitations. So, it's problematic. Alright, so when would you not want to use a beta blocker? Well, I sure as heck wouldn't want to give someone who has asthma or COPD a non-selective beta blocker because it might cause bronchoconstriction. And there are even some drugs that are alpha-beta blockers combined. So they combine a selective alpha-1 blocker with a non-selective beta blocker. That's a bit of a downturn. And so a drug like Normodyne or Corey blocks both and gives you really good results as far as lowering blood pressure. But again, we're worried about fatigue and depression. Now we're worried about the anti-diabetic effect, right? The fact that these medications can block the signs and symptoms of hypoglycemia. Again, would I want to give a drug like this, an alpha-beta blocker, to someone with asthma and COPD? Not likely. And there you have it, my friends, Autonomic Pharmacology. I am trying this video at relatively long length. Let's see what happens. Let's see if you can use it. Hopefully it's valuable to you. And I will see you all very soon.